Hello, everyone. We are right on time, and we have the privilege of having Dr. Mehra here today to talk to us about precocious puberty. Um, she has a practice in Vienna, Virginia, a private practice there, and then she sees patients virtually in Florida and Iowa and Maryland, as well as she does consultations across the country for a second opinion. And we're so happy to have her here today to hear from her about precocious puberty. So with that, we're going to jump right in and get started, and then we'll have some time for questions at the end.
Thank you so much, Stacy. I am honored to be here for the Magic Foundation. So like you said, I'm a pediatric endocrinologist. I've been practicing for over 20 years. And I currently practice in Virginia in person, but I am located virtually everywhere. So I will go ahead and share my presentation. And we will go ahead and get started. So I'm going to talk today about precocious puberty, what to expect. I want to go over some objectives for this talk. So understanding puberty, defining puberty and its importance in human development, looking at the timing of puberty, and discussing physical changes that occur in puberty. In addition, I want to define what is precocious puberty? What does that mean? Do an evaluation of precocious puberty and talk about treatment of precocious puberty. So the first thing I'm going to talk about is understanding puberty and defining the importance in human development. So early puberty, what does that mean? You may have a 7-year-old daughter who's starting developing breasts and you have concerns, and what would you do? Or you may notice that your 7-year-old son has rapid growth and has voice deepening. What would you do in that instance? Precocious puberty can lead to a variety of challenges for both the child who experiences early puberty and the family as a whole. And early puberty does impact emotional well-being and physical development. We as pediatric endocrinologists do want to have early detection because it often offers peace of mind to families, but it also paves the way for a timely intervention. So what is puberty? Puberty is really the general term we talk about for maturation from being sexually immature to sexual maturity. It's a term for the changes the body goes through during the preteen and teen years. And the biggest changes during puberty are that in children's bodies. So children usually grow taller. They grow taller in a short amount of time, and this is called a growth spurt. And they become more, their bodies become more like adult bodies. So a child's body changes into like an adult's body during that time. Puberty is caused by hormones in the body. So these hormones come from the brain as well as other organs called the ovaries in females and the testicles in males. And ovaries make estrogen and testicles make testosterone. Girls usually start puberty between the ages of 9 to 12, and boys usually start anywhere between 10 to 13. Typically for girls, they grow breasts, they start having a growth spurt, and they may see changes in the size of their labia, or and they will start to see the development of pubic hair. And then 2 years after breast development starts, girls usually get their period. For boys, they have testicular enlargement, they have hair in their private area, they have changes in their voice, they also have a growth spurt, and they get hair under their arms and their pubic area as well. And both boys and girls get pimples on their face. And so it's important to recognize some or all of these signs can be seen earlier then 9 for girls, and boys 10. And really, early precocious puberty really is when it happens earlier than that. So, we really define precocious puberty as development of pubertal signs before the age of 8 for girls and before the age of 9 for boys. And really, when puberty happens, depends on genetics. It also depends on nutrition for the child. So underweight children typically go through puberty a little bit later, and children who are overweight have been known to go through puberty a little bit earlier. So again, there's, pubertal changes for girls, 5 stages. We see that hormones are released, mainly estrogen in girls. The ovaries get bigger, girls get breast buds, they have a growth spurt, their body shape changes, and they have body odor, underarm hair. Their body hair typically gets thicker, and they can have periods, and undergo the process of ovulation every month until their final height is achieved. Typically, that is by the age of 14 for girls. In boys, we see that for them, their hormones are released, mainly testosterone, the testicles and the scrotum grow, they have some sperm production. Boys have a growth spurt, their body shape changes also with muscle development, their penis gets longer, and they have changes in their voice. They can have wet dreams and ejaculation, and their facial hair becomes more noticeable. And then the full height for boys typically is achieved when they're about 16 to 17 years of age. So precocious puberty is a medical condition characterized by the early onset of puberty. So for girls, signs of precocious puberty include development of breast tissue before the age of 8 and a menstrual cycle before the age of 10. And for boys, you can see testicular enlargement and deepening of the voice before the age of 9. Precocious puberty can have significant implications, not only for a child's physical development, but also for their emotional and psychological well-being. So it's very important to manage this and address this early. The psychological issues that I talk about for girls are that girls may not be ready to get their period, and they may be treated older than they are. And these emotional difficulties can occur from being treated older than they are, from thinking that they're going through puberty faster, and really not knowing what's going on, not to mention the hormonal shifts that occur with their moodiness and behavior changes. There can also be some social struggles from growing up too fast and receiving unwanted attention. And really the consequences beyond the emotional are also physical. So girls can have a premature growth spurt and end up being shorter than we would expect for their age. So they typically go through puberty a little bit earlier, have a rapid growth spurt, their growth plates close, and then they have early menstrual cycles. Same thing for boys. Boys typically, grow through puberty quickly, have a premature growth spurt, and then can have a shorter adult height because their growth plates close. Children may also feel self-conscious or experience bullying due to perceived differences, leading to low self-esteem and social challenges. And so this early maturation that they have can disrupt childhood and cause lifelong psychological impacts. And families must deal with the social struggles and help their children cope with the challenges of growing up too fast. For example, talking to girls about how to change their pads when they are 9 or 10 years old. So when we talk about precocious puberty, we're really talking about the onset of the physical and hormonal changes that occur during puberty, but it typically occurs earlier. So the average age for breast development for girls is 10. The average age of a first period is 12. And typically in precocious puberty, we see the normal things that happen during puberty, they still occur, but they occur at earlier and sometimes faster rate. Same for boys. So, the average age is between 10 and a half and 11 when we see boys start to go through puberty. But for boys who go through puberty early, we tend to see that earlier in age. And it is actually more common for us as pediatric endocrinologists to see girls go through puberty earlier than boys, but that depends on if they have syndromes or certain genetic factors. Now, for both sexes, a spurt in their height signals the start of pubertal development. So typically for girls, the first thing we see is breast development, and then we see a growth spurt. So they're growing faster than their peers, and the same thing for boys. So they do grow. It takes boys a little bit longer to grow, but they typically, in precocious puberty, they start to grow very fast compared to their peers. We may also see acne as an emerging sign of these changes in sex hormones. Children develop these, body odors typical of, adult body odor, and they get growth of underarm and pubic hair as well during puberty. In girls, they tend to have their period 2 to 3 years after the breast development starts. So, that's something to be aware of. And that's what most parents are worried about, that their daughters are going to have their period early. In boys deepening is a later occurrence in the pubertal sequence. So we typically see that later, but if you see that early in boys, that's a sign that they have increased amount of male hormone. So yeah, talk about why this happens. Why does early puberty happen? Well, early puberty happens from the early activation of the hormones that control puberty. And the hormonal regulation of puberty actually occurs in the hypothalamus, so in the brain, and in the pituitary. And there are pulses that are released by the pituitary that go to the ovaries, that signal the ovaries that it's time to go through puberty. And in precocious puberty, this happens early. This happens earlier than we would expect, and so you still have the hormonal pulses that occur. Now, this is what we call central precocious puberty, which is one of the most common types that we see. But this is the main reason that children are going through puberty early, because of early activation of the hypothalamic pituitary axis that we talk about, which triggers production of sex hormones and leads to sexual maturation. So central precocious puberty, again, one of the most common types. It involves the premature release of these hormones from the brain's pituitary gland, which stimulates the body's sexual development. There's also what we call peripheral precocious puberty, which is not signaled by the brain, but oftentimes there can be other causes of this. There can be tumors in the adrenal glands, which are areas that sit above the kidneys. There could be tumors in the testicles or the ovarian overproduction of these hormones. Also, if the child gets exposed to estrogen, for example, if mom's taking estrogen or there's dad's on a testosterone type of cream, and the children get exposed to that, they can have signs of precocious puberty early. So these are not typically things that we see that come from the activation of the brain, but typically either at the level of the ovary or the adrenal gland or the testicle, or exogenous. And then there's certain genetic conditions. For example, there's a genetic condition called McCune-Albright syndrome, where we see children who have early puberty, and typically they have other signs and symptoms. They have sort of a darkening of their skin on one side of the body, which are called cafe au lait spots. They can have abnormalities in their bones, which is called fibrous dysplasia, and they can have early puberty as well. And so important to look at those, evaluate children for genetic conditions as well. Now, sometimes we don't know why puberty happens early. Sometimes it may start early because the child's body might just be ready to go through puberty earlier than other children. And this can be normal and not caused by a medical problem. Excess weight has also been implicated in causing puberty early. And so we saw that during the pandemic. We saw a great number of girls who started going through puberty early, and a lot of it was because of excess body weight. But we know that excess body weight is a contributing factor. There's certain genetic factors that play a role as well. So there's gene abnormalities that have been discovered recently that can trigger the body to go through puberty early. And oftentimes there's a family history of somebody else in the family, a mom or dad who went through puberty early. And other causes, like we talked about, external exposure to sex hormones, certain medical conditions like tumors in the brain, congenital adrenal hyperplasia, and other types of tumors that are on the testicles. Recognizing and diagnosing early puberty is really critical for effectively managing and treating the condition. So when a child displays signs of early puberty, like breast development in girls or testicular enlargement in boys, a medical evaluation is needed to confirm the diagnosis. And usually we as pediatric endocrinologists do blood tests, bone age assessments, and then imaging studies in the form of MRIs or ultrasounds. And so the typical battery of tests we do are the blood tests for hormones, and we measure the estrogen and testosterone levels, as well as the brain signals. We do a bone age. We sometimes do what's called a GnRH stimulation test, which stimulates the body to make estrogen, and then we capture those levels. If there's the initial tests are inconclusive, the MRI can be done as well, MRI of the brain, and then ultrasound of the ovary or testicle as needed. It is routinely advised for children to be evaluated by a pediatric endocrinologist who specializes in the hormone disorders of children and can further guide treatment and long-term management. And treatment really, for central precocious puberty is to give treatment to interrupt the early start of puberty, to stop the effect of puberty and its long-term implications. Really, we need to identify, though, what is causing precocious puberty. And if it's central precocious puberty, we have different medications that we've used for many years to stop it, and then we tailor the treatment appropriately. And part of managing precocious puberty is monitoring the bone age and looking to see if physical development is in line with the child's chronological age. Medications also play a central role in the management strategy, and these medications can be given in the form of LHRH analogs that are typically given as injections or implants, and they stop puberty until a normal age of puberty is reached. So most people ask, when do we stop, these medications? And usually around the age of 10 or 11 for girls. And then for boys, we kind of tailor it also based on their bone age. In more complex cases, like when the puberty is a result of tumors or genetic defects, then we can, we need to tailor the treatment based on what the cause is. Surgery can be something that we do for removing tumors that are causing overproduction of hormones to help restore the normal pubertal levels and slow down the premature pubertal development. Again, the reason we care about it really is because, kids are not ready to go through puberty early. They can end up shorter than they're expected to be. And also if they have tumors or they have other causes, we need to identify those quickly. In addition to interventions with medications or surgery, monitoring over time with imaging tests, x-rays, MRIs, and ultrasounds may be required over time. And we really need to tailor the treatment based on this evaluation. The aim of all treatment is to stop or reverse the signs of early sexual development and prevent an early growth spurt, accelerated bone age maturation, and then compromising of the adult height, and then also preventing early menses. Children typically show improvement within 1 year of therapy, and these drugs are known to have minimal side effects, although some of them can cause some weight gain. When we talk about adrenal hyperplasia or tumors of the adrenal glands or sex organs, we can use medications to stop the effect of these excess hormones as well. And if there's a tumor, surgical removal is often the preferred treatment to stop the premature hormone development and normalize pubertal development. And I think that was my last slide. Yeah, that's my last slide. So I will open it up for questions at this point.
So there's a Q&A button at the bottom on my screen, it's at the bottom, but wherever your bar is, there's a chat one, but there's also a Q&A one. So you guys can submit your questions to the Q&A one, and then I will go ahead and read those. Okay, I'm going to go ahead and just read the first one. How far along can you not treat? If a girl has her period, when is it too late?
So if a girl has her period, I mean, that's typically the point that we don't recommend treatment, to be honest. So it really depends on what her age is and what our expectations are. So if you have a girl who's, 8 and she has her period, maybe a good idea to talk to your pediatric endocrinologist to see if that's reasonable to stop puberty and what treatment options are available. Oftentimes, if a girl's had her period early, she's already had her growth spurt. And if everything else looks normal, she's had her growth spurt, she's gone through sexual maturity, and she's having regular cycles and able to handle it, and we may not have to do anything. If there is a question of trying to preserve adult height, then we can try some treatment options, but really that would have to be tailored by your pediatric endocrinologist as far as which treatment to give. Do you want to give a treatment just to stop the period? Do you want to give a treatment to help with final height prediction? And how short is she? And what do the periods look like?
Great. Okay, can you see bone age advancement without increase in testosterone in boys?
So I'm sorry, the question is, can you see bone age advancement without the increase in testosterone? Yes, you can. So you see it typically in boys who are overweight. So excess fatty tissue can lead to increased estrogenization of male testosterone, and that advances the bone age. So yes, you can see bone age advancement in boys and girls, even if their hormone levels are low. And the most common thing that causes that is excess weight.
Great. How much time is usually left to grow once we see that a child has precocious puberty?
So really, again, it depends on what their bone age is. So if a child, has had their menstrual period for a girl, the typical bone age that we see, girls have their menstrual period is 12, and girls have 2 years from the time that their menstrual period. Girls have 2 years from the time that they start breast development to the time that they get their menstrual period. So if, their bone age is 12, they get their menstrual period, then they have 2 years after that point to grow. So it's about 2 years. Again, if they go through puberty rapidly, though, it may be slower than they may have less time than that. So really the bone age monitoring is really important in that case.
Great. Okay, so this next one has some specific personal things. So maybe at the end, do you want to give kind of your information? Oh wait, I see it up there. I think maybe an email or something might be more appropriate. So I'm going to kind of generalize the question. It's basically the puberty signs are mostly pubic area, but not other signs. And the doctor's thinking that a puberty blocker is not appropriate. So the question is an aromatase inhibitor still appropriate if the puberty blocker isn't?
So if the aromatase inhibitor is being offered, that may be to allow for a good, final height, or to help the child grow. So what we do is, we do the hormone evaluation for estrogen or testosterone, and then other hormones called LH and FSH, which are the brain signals. If those hormone levels come back low, we can't stop puberty. So the puberty blockers that we typically talk about are, I'm going to go back a little bit in my slides. So the puberty blockers that we talk about are these ones here. And so, these medications are typically given if your brain signals are high and you have elevations of estrogen or testosterone. If those brain signals are not high, there's nothing to block. So you can't give these medications. In which case, if it's excess pubic hair, excess hair under the arms, increased body odor, that needs to be evaluated. Those hormones need to be evaluated. And if those hormones look okay, but the bones are continuing to advance, then in that case, maybe an aromatase inhibitor would be helpful.
Okay. And then I'm thinking, I'm going to put your contact information under this question because that might be one where they could contact you for
Yeah.
the more specific.
Okay.
Do you have an email you want me to put in there or put in your website?
Yes. So I have my information right here.
Okay. So I'll put that one in there. So then we'll just move on to the next one. Does growth hormone therapy have any effect on puberty timing?
Typically, no. Growth hormone therapy does not have an impact on when puberty happens. However, growth hormone itself can sometimes lead to bone age advancement. So if you're seeing the bone age advance with growth hormone, that's what can lead to early puberty. Does that make sense? So if you have a bone age of 8, and you're on growth hormone, and then the growth hormone over time sometimes can accelerate. I've seen that in practice, that the growth hormone itself can advance the bone age. Once that bone age hits 10 for a girl, then we see that they do start to have some signs of puberty.
Okay, thank you. This says, what is the underlying cause of precocious puberty in Temple syndrome, and what are the potential risks and side effects of puberty blocking hormone therapy?
Yeah, so we're just talking a little bit before the session about Temple syndrome and early puberty. And my understanding is that Temple syndrome, really the main cause is central precocious puberty. So that would be puberty that starts in the brain, early activation of puberty. In other conditions like McCune-Albright syndrome, for example, the cause of early puberty is at the level of the ovary. So there's, small ovarian cysts that form, or enlarged ovaries that form and overproduce estrogen. And really looking at the cause of it is really important. So if you have what's called central precocious puberty, typically we start treatment at the time that we see those hormones elevated. So if the child is 5 and we're starting to see elevations of the LH, elevations of the FSH, elevation of testosterone, estrogen, that's a typical time frame that we would start the therapy, especially if their bone age is advanced. And then, for McCune-Albright syndrome, for example, sometimes I've monitored that over time to see what happens with the estrogen levels. But if they start to increase or the bone age starts to advance, then we had talked about treatment at that point. And the puberty blockers or GnRH agonists are not helpful initially in McCune-Albright syndrome.
Okay, thank you. This next one has some more personal specific things again. So I'll send a message about that stuff. But I think in general, the question is, it's a girl who is about to start Bensolvi, and there's no period yet, but it says any tips to deal with the pain during and after application.
Yeah, so Fensolvi is a subcutaneous injection. I don't know if that's what the question is, but so the purpose of Fensolvi is to stop puberty. So that is a puberty blocker, 6-month puberty blocker, subcutaneous injection, meaning it's given, in the fatty tissue. It's not as painful as Lupron. So when I first started practice, fellowship, 2004, 2001, we were giving Lupron injections, which are intramuscular injections into the muscle once a month. I started doing less and less of that. And now we have this, Fensolvi, there's other treatments that we do in the fatty tissue. There's, pain at the injection site, which is the typical thing that, your child will experience. But the medicine really lasts about 6 months. So usually it's like 2 injections that they have to have, or depending on how old they are when they start. If they're 5, then, I usually stop when they're 10. But they get the injections, and what you will see over time is you may see a little bit of vaginal bleeding because if those estrogen levels are already high, and then you drop the estrogen levels with the Fensolvi, you will see a little bit of vaginal bleeding, but that will stop. And then you see reduction of breast tissue, you see slowing of growth, and really it stops all those effects that you see during puberty.
Okay. I have another one that says, is it ever too late to start treatment?
I would say, yes. I mean, for a girl, if she started having her period and her bone age is, closed, or growth plates are closed, I don't see utility of stopping puberty at that point because she's already progressed through puberty. Um, same thing for a boy. If they've gone through puberty already, and I've seen several boys who've come to my office recently that they've already gone through puberty and their final height is, already, what it's going to be because their growth plates are closed. In that case, we don't recommend treating because the risks really outweigh the benefits at that point.
Okay. If bone age advances rapidly in 6 months, along with rapid puberty advancement at a typically normal puberty age over 10, then what are the potential next steps?
Okay, so I'm sorry, I don't understand the question.
Yeah,
Could you
so
repeat that
if bone
again?
age advances rapidly in 6 months, but it's at a typical puberty age over the age of 10, then what are the potential next steps?
Yeah, so really treatment of early puberty or precocious puberty is if you see pubertal signs before the age of 10 before the age of 8 for girls and before the age of 9 for boys. So if you're not seeing signs of puberty early, there is not a recommendation to treat with puberty blockers. Because if they start going through puberty at 10, but they have rapid progression through puberty, it could compromise their final height. But the recommendation at that point really is not to give a puberty blocker, because estrogen and testosterone are really important for bone development. They're important for growth overall in children. And so there's lots of other factors that are in play. So really that approach would probably have to be tailored with your pediatric endocrinologist to see what would be the options. But typically if they start puberty at a normal age, we don't recommend treatment.
Okay. I do have a question about blood tests, and that's what blood tests should the doctor be requesting for girls, and which of the blood tests are from the brain indicating central precocious puberty?
Yeah, so the hormone levels that I recommend getting for central precocious puberty usually are, it's called a LH, so luteinizing hormone, FSH, follicle stimulating hormone, estradiol. Those are the three typically that we do. And I do thyroid studies too, because sometimes the thyroid hypothyroidism can actually cause some signs of early puberty, interestingly, by activating the ovary. So I typically get, LH, FSH, estradiol, a bone age, and then I do thyroid function tests also. Also evaluating to make sure the child's not overweight. So doing some of the labs, for diabetes, A1C, and cholesterol if the child's overweight, because those need to be addressed too. But typically from a hormone perspective for puberty, it's really LH, FSH, estradiol, and thyroid function tests.
Great. And then I have a question. I have a couple questions in this one. How often do you repeat labs? So this is somebody that is on Lupron injections. And then what's the typical bone age, bone advancement in treatment?
Yeah,
I
so
think
what we
they're
want is
all
the
in the
bone age
treatment.
we want the bone, I'll take the last question first. So we want the bone age to be stable. So we want the bones to advance either, not advance much or advance along with the chronological age. So for example, if the child is 8, the next time we do a bone age, we want it to remain 8. Or if the child's 9, we want it to be, at 9. Or sometimes we see that the bone age doesn't advance at all. It just stays at where it was. And that's typically what we want. We want stability in the bone age. We don't want rapid increase in the bone age, because what advances the bone age is estrogen or testosterone. And so if those levels are low and we've suppressed it, we should not see a bone age advancement. Now, growth hormone can sometimes cause the bones to advance, so we can sometimes see that. But what advances the bones rapidly is the estrogen and testosterone. And what was the first part of that question?
How often do you repeat labs? So this is like on treatment, I think.
Yeah,
So.
on treatment. So typically what I do is I don't repeat labs that often. I see them back in the office for an exam, and if it looks like their breast development's gone down, or the testicular size is not advancing, the bone age is stable, I may not do labs. But if I have concerns that the child has not, the puberty hasn't stopped with Lupron, then I will do the labs. And that may be, in 3 to 6 months, depending on what I see. But I typically see kids initially at the 3 month mark and then at the 6 month mark, just to make sure that things are working.
Okay. Does ADHD medication have impact on puberty?
What I see for ADHD medication is actually that kids typically have less of an appetite and their weight is lower, and they actually don't go through puberty early. And sometimes they go through puberty late because of low body fat.
What are the potential risks and side effects of puberty blockers? I
So
think we did that
what
one.
we have seen is that initially you can have pain at the injection site, especially with Lupron. There's another type of medication that is given that's called Suprelin, which is an implant that's placed in the arm that can be good for up to 2 years. And so the risks of that are that you have to get surgery, anesthesia risk, um, you know scar tissue that forms at that site. Sometimes I do see weight gain, especially with Lupron. We see some weight gain with a significant weight gain, 10 to 15 pounds of weight gain with that. Sometimes nausea, vomiting, headaches, or signs that you feel like hot flashes, and that tends to go away over time. Those are the typical side effects that we see with some of these puberty blockers. There were reports in the past about maybe having an impact on bone health in the future, because estrogen, testosterone are important for strengthening of the bones. And during puberty, making sure that kids are developing their bone bank. But we haven't really seen any studies that have showed increased risk of fractures in children who've received this treatment. And then the other issue really is that we can't really put all our money on the fact that these puberty blockers will help our children attain a otherwise quote unquote expected height for the family, because some of these kids do end up being shorter than we would expect for their family, not because of the side effect of the medication, but because of the effect of the puberty overall does have an impact on their final height. But those are the typical side effects that we see. And again, these are reversible. So usually once we stop the treatment, usually within 6 months, puberty starts again in a normal pattern.
So we have a couple questions that are related. One, so about supplements. So are there supplements for bone health or anything else that you recommend to take while on treatment? And there's another one that is, should my child take vitamin D and calcium?
Yeah. So that's what I recommend. I usually recommend everybody take calcium and vitamin D while they're on the treatment.
Great. Can you talk about ending treatment for females, how to know when to take the implant out, and timeline for progression of puberty after treatment stops? For example, it's they started treatment at age 4.
Yeah, so I typically stop treatment at the time that puberty is supposed to start for girls or boys anyways. So for a girl, if they're on treatment since the age of 4, then around the age of 10 or 11, I will stop it. And I don't go beyond that time frame period. Again, what ends up happening is that you do slow the growth. So you slow the rapid growth that these children are having during puberty. But if you leave it in too long, one of the side effects, I will say this, is that growth slows too much. So then they don't grow as well. And so you don't want to leave it in too long. So I would say taking it out or stopping the treatment around 10 or 11 is typical for girls. And then anywhere from 9 to 11 for boys, we, stop the treatment. I will say for girls, more often, 95% of the time, the reason for early puberty is idiopathic, meaning we don't know why they go through puberty early. There are certain genes that we don't have the laboratory evaluation testing to do, but it's idiopathic. We don't know why. And so for girls, typically I will stop, and precocious puberty is more common in girls. We see a lot more of it in pediatric endocrinology as more of a benign issue, and we stop it. In boys, when I see puberty early, I'm more alarmed in boys because it is more rare. And so stopping the treatment really depends on what the cause of that early puberty was.
Great. What options do you have when you have advanced bone age without central puberty?
So again, if you have an advanced bone age and if it's not due to weight, then looking at other hormones. So if it's not due to central precocious puberty, the next thing I look at is what is their weight or BMI, because increased weight and obesity in particular does advance the bone age. So let me talk about lifestyle changes, healthy weight. If that's not the case, and there's other factors that we see, for example, in a boy, if the testicles are enlarged early, or they have rapid increase in the amount of pubic hair they're having, voice changes, then we evaluate for other hormones that could be causing, or other areas that could be causing early puberty, to testicular ultrasounds, adrenal ultrasounds, some of those labs, and then do the treatment based on that. And once we identify the source of treatment, then we can say, is treating this going to stop the advancement of the bone age?
Awesome. Twice now it has been said that growth hormone advances bone age. Is this a bigger concern for those on GHT?
No, it isn't. But sometimes people want to be on both. They want to be on growth hormone and Lupron. And so it's important to identify that sometimes, we do see that. So even on growth hormone, monitoring the bone age is really important. And those of you who are, have children on growth hormone, we typically do a bone age at least once a year, just to make sure that they are not advancing the bone age, quickly, because growth hormone and the hormones, testosterone or estrogen, together can advance the bone age too. But we typically don't see it as much with the growth hormone as we do, in children who are going through puberty early.
Okay, I'm going to stumble through the wording on this next one. Does Strensiq for hypophosphagia or HPP itself interfere with growth hormone treatment or expected outcomes for SGA kids?
Sorry, I didn't understand the question.
I'm not familiar with this, so
doesn't sound like it's related to puberty though, right? Is it a growth hormone question?
potentially. I'll send a message about that one.
Okay.
So it says, you mentioned that treatment is not recommended after a period starts. If a daughter is in advanced puberty at age 10, which is normal for both sides of the family, would puberty blockers be the first line of treatment for height?
Yeah, so again, that would have to be tailored to the child. Really looking at the bone age, what their height is, and really tailoring it then. The typical time frame to stop the puberty blockers is between 10 and 11.
Gotcha. Could you please share your thoughts of CPP for boys versus girls? We were under the impression that boys are not as common as girls.
That's correct. Yeah, boys are not as common in girls to have central precocious puberty. And like I said earlier, girls, very common. 95% of the time when we see central precocious puberty in girls, idiopathic. But boys, more rare to see central precocious puberty in boys.
All right. Are there new treatments that show improvement in treatment compared to Lupron for central precocious puberty?
Yeah, I mean, I don't actually use Lupron as much anymore. I think Lupron was the gold standard for precocious puberty. Even when I was in training, I used Lupron monthly injections, and they were very, they were very effective. But I had people who just weren't, kids who just didn't want to get an injection once a month. It's pretty painful. Their legs were sore. It's kind of like getting a flu shot every single month. And so there were issues with treatment adherence, like children just didn't want to have the treatment. And then we spaced the treatments out for Lupron. There's Lupron, formulations that are every 3 months. Those are very effective also. But then when Suprelin came out, or the implant Hysterelin, more of us started using Hysterelin implants because kids were not missing school, parents were not taking time off of work, and the implants lasted, initially a year, and then the studies came out saying they last 18 months and up to 2 years. And so those implants were pretty effective in stopping puberty and really having, no missed time from school or work. And psychologically, the children weren't really thinking about it quite as much. So, we're using more of that. Now I'm running into the problem that I don't have enough surgeons that I can refer to who can put the implants in and take them out. So I'm using more of the Spensolvi, which is 6-month injections, to help. But all of the treatments are effective. So again, tailoring the treatment to what you want. But Lupron has the high, has been used the longest.
All right. Well, adding on to that, somebody has a question about your opinion of Triptador for CPP.
Yeah, I think it's effective. I think they're all effective in treatment, and helping to prevent precocious puberty from progressing.
This one, I'm going to read it and then you can decide if it's one that should be kind of tailored, but this person's asking if the blood tests don't indicate CPP yet, but that is likely coming, but bone age is mildly advanced and slight breast buds, would you recommend doing something like a pelvic ultrasound? Because I know you mentioned that.
Yeah, so again, I have to see what the labs show. Ultrasounds, when I do ultrasounds, I order them pretty non-invasively. So if it's needed, we don't do transvaginal ultrasounds in kids. We do them from the abdomen, above the belly. And so, if there is, any question about it, it doesn't hurt to do an ultrasound. It's kind of annoying for the child because cold goop, on their belly, but it's pretty safe to do. If there's a question about, where these hormones are coming from, is it from the level of the ovary? Is it from the brain? Probably a good idea to do the ultrasound. We can also see that with the ultrasound, see if the uterus is enlarged, the uterine stripe is enlarged. Sometimes we do stimulation tests, so GnRH stimulation tests, where we give an injection of a medication and then measure labs, 1 hour and 3 hours later for the pubertal hormones to see if we can stimulate a response. So that's an option as well.
Gotcha. Does the Suprelin treatment shrink the uterus or ovaries back down to the appropriate size like it does for breast tissue? And if not, does stopping treatment increase the timeline of puberty progression?
Yeah, so, the Suprelin, has the effect of suppressing the pubertal hormones. So lowering the LH, lowering the FSH, and then ultimately lowering the estrogen. And lower estrogen levels are what lead to, the breast tissue going down. At the same level, you wouldn't see the ovaries or the uterus grow because estrogen causes those to grow. So that decreases that as well.
Okay. How accurate are bone age scans? This person asked, my daughter had a bone age that showed 12.5 and 6 months later, another bone scan said 11.
Yeah, I mean, the bone age, to be honest, the bone age is a subjective test, okay? Meaning that it depends on who the reader is, who's reading it, how much experience they have in reading the x-rays. The bone age, if you ever look at a bone age book, I always show my patients in my clinic what a bone age looks like, what the bone age book looks like, and what we're looking at. And so there is some variability with that, depending on who's reading it and what that x-ray looks like. So it's sort of an estimate of where they are in their chronological age and their bone age. So we have to look at all of those things.
So I just love what you just said, Dr. Mehra, about how you show your patients your bone age book and really explain things just your patient-centered and patient-focused care. And I know that from my experience with Magic, that's what our parents want, is like being educated, giving us all the knowledge we need to continue to ask good questions and monitor. So I just am really thankful to
Oh,
participate in
good. Yeah. I mean, I think
everybody.
that's important to know because I think there's a lot of things. So my goal always is to say, let's not like Google things because there's stuff all over the place, but just to have you understand what the process is. And the bone age, is really, I mean, we do a lot with the bone age as pediatric endocrinologists. We look at bone age for growth. We look at bone age for puberty. We look at bone age to see delayed puberty, early puberty, all those kinds of things, even, weight concerns. And so I think it's important to understand that it's not a be all end all. Like one endocrinologist could read it at 11, another one could read it at 12. You really have to know what you're looking for, but the importance is just for looking at it over time. So even in that case, where, once it was read at 12, another time it was read at 11. Well, mainly what that means to me is that it's probably okay because your bone, child's bone age is not progressing. It's not like the growth plates are closed. And so that's probably means it's pretty stable.
Great. So we have just a few more minutes. So if anybody has any last minute questions, you have to get them in like right now. We don't have any standing questions anymore. So if anybody has any more, you have to type really fast right now because we're going to kind of wrap it up. But yeah, again, I just feel like I'm taking a bunch of notes because my child does have Central Precocious Puberty that will be coming. And again, I just always appreciating being educated because us as parents, I'm guessing there's many parents on here. We're the ones that are looking out for things every day, and we like to be trusted with the knowledge so we can kind of get good treatment and speak up for our kids. So I know some people asked some specific questions today, and I just think I'm really grateful to have you here today for all of our parents.
Yeah, and always, don't be afraid to ask. I think there are a lot of, I mean, I think that's my, last point I want to make is don't be afraid to ask. And also, sometimes your kids are getting older and they're taking baths by themselves and taking showers by themselves, and you're not really noticing some of those things like you were when they were babies. But just pay attention. If your child says, my chest hurts, over the breast area, it's probably real. I mean, it's probably, or they hit something and their chest hurts. It's probably real, so probably a good idea just to get that evaluated and checked out.
Yeah. So there's one more I think we're going to do. Does Lupron affect egg health or fertility for the future?
No studies that I know of have shown that at all. So there's nothing, and no one's come back to me in the last 20 years to say Lupron therapy prevented them from getting pregnant. I will make a comment though that some things that we see during early puberty, for example, early development of pubic hair, or hair under the arms, which is called premature adrenarche, or premature pubarche, which I didn't really talk about too much, but sometimes we see that those children who have early development of pubic hair, hair under the arms, body odor, can have a higher risk of developing PCOS, the girls in particular, polycystic ovarian syndrome, which is implicated in, fertility. That's a separate issue. We don't treat those children with Lupron, but, there are certain things that do impact fertility, premature pubarche or adrenarche, maybe a risk factor for having PCOS, but not Lupron in particular.
Okay. How much weight gain should be expected with Lupron? This is scary for Temple syndrome kids who already struggle with weight.
Yeah, I mean, sometimes, it can be up to 15 pounds. It can be. So, if I see a girl who, is, or a boy even struggling with their weight, we always counsel them, really diet, exercise, lifestyle changes, because it's real that you can see weight gain. And same thing for somebody who asked that question about, what to do if a girl has her period already. If you want to stop it, for example, certain medical conditions that, kids are not able to take care of themselves. If you want to stop the period and do, we were doing Depo-Lupron for many years, that caused a 15 to 20 pound weight gain. So same thing, it's in Lupron. So important to be aware of that can happen. And sometimes, that's reversible when we stop it, but If you have that weight gain, then you can have other health related issues related to that.
Okay, so we'll do one more question. What's the difference between early adrenarche and central precocious puberty?
Yeah, so adrenarche really means increased activation of the hormones of the adrenal glands. So adrenal glands, sit above the kidneys, and in girls, they're responsible, in girls and boys, they're responsible for, pubic hair under the arms, acne, body odor. Boys have it too, but typically boys have those things happen with testosterone. But what happens in early pubarchy or early adrenarche is that sometimes those glands wake up a little bit early, the adrenal glands, and they make a little bit of extra hormone. And some kids are more sensitive to those hormones. So you see the early development of pubic hair under the arms, body odor, and acne. Their bone age typically is not advanced. They do not have a growth spurt. And the hair, the pubic hair, the acne, those things increase slowly. So as long as you're not seeing a rapid increase in that development, then we don't tend to worry about it too much, but we do tend to follow it over time.
Okay. So that is going to wrap up our seminar for today.
Okay, thank you.
Thank you so much for your time today. We really appreciate it.